So we shall now go on to our next speaker, Dr. Savio Pereira, another young dynamic surgeon from a consultant phaco and a refractive surgeon from Netradama Group of Hospitals. And he has another brilliant video to show us and a learning tip here. On to you, Dr. Savio.
Thank you so much, Chitramurthy ma'am, for giving me the opportunity. Thank you, ARC, for this really great initiative. And the video which I'm going to share is something which we can all learn, a small tip. Basically, this is a partially observed cataract. And you can see over here, the patient gave a history of trauma. It's partially absorbed. Usually contusion injuries cause a partially absorbed cataract. Now, you may go ahead with a regular cataract surgery, but at the end of the surgery, when you see that there's a lot of fibrous sheets running across the visual axis. Now, what options do you have at this point? Yes, you can just put in the lens and do a YAG cap later, but you have to wait for about 3 months. It's not very visually gratifying. So over here, what I want to say is that you can actually peel these membranes off. The forceps which I'm using is nothing but the same Rexis forceps. It's a micro Rexis forceps, no financial interest over here. But what you notice that there are different fibrous sheets running. So basically, you have the anterior epithelial cells, which lead to fibrous sheets formation, and the equatorial epithelial cells, which lead to formation of these bubble-like cells that form as sheets. So you need to get rid of both. So you can actually close the forceps and get to the edge of the sheet. And you can, once you get it off, you can grasp it and you can see that the extension, though the sheet appears really small, here I'm using the retro illumination mode. You can see to what extent. One of the tips while doing this is that whenever you're putting viscoelastics, don't overfill the chamber because you want the capsule to be dome shaped upwards. Here you can see it's a little bit overfilled. Use the retro illumination mode on the microscope if you have it. Coaxial, stereocoaxial really works. And you can actually peel these membranes. The other option is you can place a lens but do a PCCC. But remember, if you can keep the capsule intact, there is nothing like it because the inflammation will go on to the posterior chamber and you may end up having a post-op CME because these cases are traumatic cases. But what I want to try to indicate here is that here you can see this fibrous band and you can see these sheets of cells. You need to get rid of both. Mind you, these are very fine membranes on the posterior capsule. There is actually, we'll be careful not to grasp the posterior capsule. And you can peel it off like a Rexis. And if you see that it comes off so easily, and this is very important to clear the visual axis and see that the central area is clear. Because if you put in a lens, and if it happens to be a multifocal or a trifocal lens, these fibrous bands are going to cause a lot of aberrations. Here you can see we have removed it. This is not the CCC margin, but this is actually the fibrous margin. I'm going again over here to this part. Here you can see that this is the fibrous tag over here, and these are the sheet of cells. If you catch it and you can peel it like a Rexis, but the PC is intact at this stage. You can see the PC getting folded over here, and you can see these cells. In spite of the fibrous band coming off, these cells are intact. It's very, very important to grasp the edge, free it, and then only go around in a Rexis formation. So what I try to this is one of the techniques you can use. It's a regular forceps which you use to complete your Rexis. And you can actually peel off these membranes, something like the ERM peeling the retina VR surgeons use, but you have to go in and be very gentle. And as you can see, all the membranes come off. You have a much more clearer center from what we started off. And then you can go ahead with your case. But it's very important that once you clear all the membranes, to just inspect and see that there are no micro holes, especially or small tears, then you need to convert it into a PCCC. Here you can say, once it's all converted, I'm going ahead, placing the lens in the bag, and you can do your visco wash. And it's so much more gratifying that you can give much more better visual outcomes rather than telling the patient that you need to wait for a YAG cap after 3 months after surgery. This part I have fast forwarded, the real video is playing real time. So this is exactly, you can see lens placed in the bag and the center part is so clear. So this is something I would really like to say is we can all learn from this. And this is a thing which will really help people.
Wonderful video, brilliant video for that matter. I think Dr. Mahipal has joined. I just thought I would take your call on this, not this particular case. If it is a mature cataract with a PC plug and a silicone oil filled eye, like for him, when he was doing this, always he must have felt that if he has a PCR, he can convert it into a PCC and do it. But could this kind of a technique be adopted in that kind of a scenario?
Yeah, thank you very much. We do that routinely in the cases of silicone oil filled. But before I go on to that, well presented, great presentation. The posterior capsule becomes parchment-like. It is slightly easier to do a posterior capsular excision in a silicone oil filled eye. The fragility of the capsule is not as much as it is in a normal case. So what we routinely do is that we follow, this was described by Dr. Dinesh Talwar more than, I would say, 2 decades ago, where an interior route is followed where you do a PCC, and just by pushing in fluid through the PCC and depressing the posterior lip, the silicone oil can come out. So it is much faster. The only thing is that you have to observe the retina removal of the post silicone oil, that the detachment and everything that is settled and remains settled. So we are doing it very, very routinely, and we can do, and often they have a plaque there. So actually it's a double advantage that you are doing a PCC to remove the plaque also, as also you are removing the silicone oil. So that is what we do. And just a small little thing, what he has said is very, very right, that you have the patience to remove that. But at times you can also use hydro dissection. That means that if you actually get into a cleavage plane, that you have to just identify the cleavage plane, and then you can use actually fluid to separate it out and then peel it off. So getting a cleavage plane with a forceps or with a jet of fluid is something that is done to remove this plaque.
Yes, I truly believe a cleavage plane is important.
Visco dissection can be done with the visco.
You're absolutely right, Namrata.
So visco dissection or hydro dissection can be done.
Any other thoughts of the other expert panel? Gaurav, Ramurthy, anybody?
I sometimes do a jet hydro wash kind of a thing, but where I take the infusion cannula. I've got special bimanual cannulas which are sandblasted, and you can go in from the main port with your infusion alone, no aspiration. Go in from the main port and use the jet. I mean, it's like, because your posterior lip is depressed and the main port is much bigger than your infusion handpiece, so you have a fast flow of fluid coming on. And you can just use that to do a gentle rub on the posterior capsule, and many of these plaques just come off almost like, they are flushed off the posterior capsule quite well. And it's not risky at all, because the fluid is constantly pushing the PC away, so you'll never end up breaking the PC. So I call it as a jet wash, and these cannulas are sandblasted, so you can do a gentle kind of, all these thing maneuvers put together. But I think it's video, because some of them, these membranes will not peel. And if you, you have to kind of get a hold on it and then do this. It was a very patient job. Nicely done, Savio.
Yes.
Thank you.
Agree, Dr. Gaurav, but we need to ensure that we are not going in through the side port, like you mentioned. Somebody might just going through the side port and the chamber might suddenly, deepen. And another thing is, you can use a very thin cannula, even if it's not sandblasted, because if it's thin, then with the jet, then it becomes easier. But if it's a strong plaque, or if it's really attached, then it may not really come out.
Yeah, Savio, beautifully depicted case, and very nice.
Thank you, sir.
I differ from Gaurav, because what Savio did was the right thing in such kind of cases, because I have been doing this for last many years, and everybody, most of us must have seen, there are a number of videos I have shown, and this technique I am following, and these cases, they don't really yield with the fluid or with the bimanual aspiration also. Even if you are holding it with the aspiration cannula or bimanual cannula, the posterior capsule and this plaque, it doesn't yield or it doesn't come out. You definitely have to use this technique. And what important is that we should keep the chamber, the capsule stretched. Because it should not be overstretched, but it should be stretched. Otherwise, if it is lax, then there is still a chance of getting a tear in the posterior capsule. If it is overstretched, then again there is a chance of developing a tear because of the force of the viscoelastic or overfilled chamber. And this is the technique. And the ledge was Dr. Mahipal was saying, and what Dr. Savio has shown, and he has shown at multiple places. I think 6-7 times he has peeled off. He has, stopped it, because the membrane comes out as per own force of action and it moves along that particular direction. Then you have to regrasp, leverage it, make a ledge of it, and then again hold it and then do it. And this technique is very useful in cases of multifocal lenses, because there, in otherwise you can do YAG, because from the rest of the clear area, patient will have fairly good vision in all these cases. And you can do YAG capsulotomy if you are not removing these plaques and if you have not tried doing it, and if you don't have that much of patience. So in multifocal IOLs, if you have planned, this is the way I have done in couple of multifocal IOLs, these things, because then patient expectations are more in the early post-operative period. And this works fantastically.
Thank you. Wonderful video, Savio.
A couple of
Thank
points.
you so much, ma'am.
Great videos, Savio, and great points.
Thank you so much, sir.
I think we have to differentiate between a fibrosis of the posterior capsule and plaques on the posterior capsule. Like when you have silicone oil and the fibrosis occurs, there's no way that you can peel it off. You can only create a posterior capsular excess. So similarly, these things will work only when it's a plaque. It's not the capsule itself that's fibrosed. And especially for the youngsters, you did it so many multiple times, and it's great to see at the end of the surgery that you have an absolutely clean posterior capsule. We need to remember that PCO occurs because of the proliferation of the equatorial cells. So if there is a small plaque, small patch of fibrosis not in the visual axis, but somewhere away, it's really not necessary to go after it or chase after it, because that's really not going to interfere with the vision, even if it's a multifocal intraocular lens that you're implanting. So definitely, if it's right in the center, whatever you did, especially if it's a plaque, it's a good idea to remove it. But if it's a basic capsular fibrosis, I think it's best handled with YAG at a later point of time, and no need to go after areas which are off the visual axis.
Yes, a very valid point. Thank you very much.